Yeah, now it's
Yeah,
fine.
is it in the enlarge mode?
Yeah, yeah, enlarge mode. Please go ahead.
Uh, uh, Good afternoon, everybody. I thank Vishnu sir and Gunjar giving me this opportunity. We'll be discussing only a case-based discussion how we do osteotomy by malunited fracture. So this is a case of a 70-year-old female fall from a staircase and was not treated for about 4 months, and she came for treatment because of pain and limping. So before we plan, we must get a very good AP X-ray of the pelvis with both hips. The parameters are the LT should be just visible. The obturator foramen should be round, and we should not have a inlet or outlet view. And there should be the coccyx should be 2 centimeter from the upper edge of the symphysis pubis. Some basic knowledge. In order to draw lines, we must have a 2 points, and we can connect it with a scale to make a line. Or there is a known a line is there, a known point is there on the line, and we have a known angle. Then also we can draw a line in the space. So once we know the fixed point and the angle. So coming to complementary and supplementary angles, complementary means two angles will add up to make 90 degree, and in supplementary angle, two angles add up to make 180 degrees. So coming to the case again, so first you draw the center of the femoral head. You can use Muth circle or some software to draw that. Then you draw the center of the femoral neck, and once you get these 2 points, one line, so which will make the femoral neck axis or femoral neck line. So similarly, you draw center of the proximal femoral shaft. You have to take 2 points in order to draw one line, and then you draw the line. Now the two lines will meet at an angle, and we call it at femoral neck angle, neck shaft angle, or CCD angle, caput column diaphyseal angle. So now the question is, once we get a deformity, then how much correction we should do? So point number one is by the Keith Mayo article is it should be 5 degree more than the contralateral side. There is another point is the correction at any circumstances should not go more than 140 degree of neck shaft angle. And three is we should not take more than 30 degree of intertrochanteric wedge at any point of time. Then coming to point number one, so 5 degree more than the contralateral side, but the prerequisite is the contralateral side should not have an abnormal values. It should not be even coxa vara or should not be coxa valga. So why we should not have a correction which is more than 140 degree? Because it will reduce the abductor lever arm, which is from the center of the femoral head to the mid axis of the proximal femoral axis. If the lever arm reduces, then what will happen? There will be abductor has to work more to make a particular degrees of movement. So that will increase the joint reaction force and the friction in the joint, which will increase the cartilage wear. And also it has been seen there is increased incidence of AVN with a neck shaft angle more than 140 degrees of correction. For these regions, we don't want a correction which is more than 140 degree. So why we should not have a more than 30 degrees of wedge? Because when the person walks, the both the foot has to be on the ground. So if you are taking more wedge, so in order to bring the foot onto the ground from the abductor deformity, so there will be more stretch on the abductor. And in other words, the stressed abductor will increase the joint reaction force and will cause joint damage. For this region, in a single sitting, we do not want to have a correction or a wedge more than 30 degrees. Now coming to this case, so the contralateral neck shaft angle is 130 degree. We want a correction of 5 degrees more, which is 135 degree. And in order to get that, so 135 degree minus 90 degrees, so you get a 45-degree wedge. So we cannot take a 45-degree wedge. So we will settle down with a 30-degree wedge. So we decided that we'll do a correction of 30 degrees. So how we'll select the angle of the angle blade plate, because we'll use the angle blade plate as the correcting device. So you can, if you see this picture, there are three possible entry points for the angle blade plate. But ideally, we prefer a particular end point, which is usually the inferior quadrant and which is infrafoveal in location. So if we draw the upper limb of the osteotomy, which is the intertrochanteric osteotomy, so we cannot take the lower line as our chisel path because that is too close to the upper limb of the osteotomy. And ideally, there should be a 15 millimeter gap so that the chisel path and the upper limb of the osteotomy do not coalesce with each other. Now we want to use one cannulated screw, which is depicted by the red line. And if we want to put that screw, then the upper line will be very close to the screw. Then at the entry point, both will jumbled up. So it will be difficult. So we'll not choose the upper line as the entry point of our chisel. So what is the remaining is the middle line. So we'll select it as the entry point of our chisel path. And we know complementary and supplementary angles. So for a 130-degree blade plate, so supplementary angle is 50 degrees. They both add up to make 180 degrees. And for a 110 degree, it is 70 degrees. And for a 120 degree, it is 60 degrees. So once we know our chisel path, the pink line, so we draw the mid-axial line and we shift that line to the lateral cortex of the femur. And we find out that the angle between the pink line and the lateral cortical line is 90 degrees. So our angle of entry is now 90 degrees. So we have to choose a blade plate with supplementary angle and the wedge angle which we want to take. So combinedly make up to 90 degrees, which is the angle of entry. So now how we will select? So now the angle of entry in this case is 90 degree. So wedge angle is 30 degree. So supplementary angle of the angle blade plate to be used is angle of entry, which is 90 degree minus the wedge angle, which is 30 degrees, so the 60 degree. That means we have to select a blade plate whose supplementary angle is 60 degrees. So 180 degree minus 60 degree is 120 degree is the angle of blade plate we should use in this case. Now for a 20 degree edge, these are all calculation. That means this shows the angle of entry will change once you are using a different type of blade plate. If there is no wedge you are taking, then angle of entry is equivalent to the supplementary angle. Now there is a method too. There is a graphical method we can find out. So what if you first find out the next up angle and the desired angle you want to achieve, which is 5 degree more than the 130 degree. And then you select the amount of wedge you want to take. And then you chisel path. And then you draw your lateral cortex, which is the green line. And to that green line, you draw a red line or something line which is away from the lateral cortical line. And once you just combine these two lines, so that will give a rough estimate of the angle of the blade plate you should be using for a entry. So to have correct and the angle of entry. So and angles it find an idea of how what will happen if
Dr. SUMANYU, I think your audio is a bit disturbed.
Basically, it's the internet problem, nothing else. Yes.
am I audible now, sir?
Yeah, you are audible now.
Okay, so this left side picture, there are three axes. You can see the left side is the mechanical axis of the lower limb. The central one is the vertical axis, and this the femoral axis is the right side. So usually the mechanical axis has a 3 degree to the vertical axis. So now we'll see what happens if we do a valgus and varus osteotomy. So you can see in this picture, once you do a 30-degree valgus osteotomy, the yellow line is the mechanical axis is very little deviated. It is because the theory is once you move away from the knee joint line, the impact of the osteotomy in shifting the mechanical axis reduces. So we should not be bothering much how much our osteotomy, how much mechanical axis will go into varus or varus. So you can see in this particular case, we have done a 30-degree valgus correction, but you can see the mechanical axis has not shifted very much. And even if you do a varus osteotomy also, the mechanical axis doesn't medialize too much. Now coming to one case example, a 72-year male fall in the bathroom. He has an parodontocondric fracture. So what somebody has done a interlocking nailing using a PFN. He also had his knee replaced few years back. And in 3 years, we can see there is a collapse and there is also an implant breakage. So we have found out that the next up angle is 108 degrees. And then we decided that we have to take contralateral side angle is 131. So for +5 is 136 degree. So the angle of correction needed is 136 minus 108 is around 27 degrees. So roughly it comes around to 30 degrees of wedge. So you can do a bone ninja simulation. You cut 30 degrees and you see what is happening to the final accept angle. So what we did, we inserted a blade plate and we take a 30 degrees of wedge. Basically, I didn't have to take much wedge because already there is some bone loss was there. And we just put our chisel in a particular path and then angle of entry, and then we get a desired correction. And we put a circlage wire for another stability. So you can see here, we take a long leg X-ray. You can find it a little bit lateral deviation of the mechanical axis, but not too much. This is a 5-year follow-up. So the patient was able to walk. The fracture is fully united. The SS wires are broken, but otherwise there is no loosening of the implant. Have all the photographs, but this is exactly what we do. So you find out your particular angle of entry and desired path, check it in the AP and lateral, and then you put multiple wires. You make a converted drill bit to make an entry point, and you pass your chisel on CM control. And once that is done, you pass 2 wires. The upper limb of the osteotomy is usually perpendicular to the mid-axis line. Then the desired angle, you excise, you pass, and you laterally translate, and then you fix it. That's it. Thank you.
Thank you, Dr. Sumanyu, for your excellent presentation. If anyone wants to ask any question to Dr. Sumanyu, sir.
Can I ask a question?
Yes, definitely, sir.
Yes.
Sir, it's all about the coronal plane, what we talked about. But what about regarding the sagittal plane? Now, how do you take it into consideration while planning those?
For sagittal plane, so when suppose there is a apex anterior or apex posterior deformity, so what you do is you pass your in the chisel guide there is a shaft, so you angulate that shaft along the proximal part of the proximal fragment. So if there's a, let's say there is a apex anterior angulation, so you angulate the shaft of the chisel guide and anteriorly. For a posteriorly, you again angulate posteriorly. So once you take a osteotomy cut, so once you reduce the shaft of the angle blade plate, it will automatically correct that apex anterior or apex posterior angulation.
Thank you, sir. I think what you want to tell me is like you put a like closing wedge type scene, like anteriorly.
Yeah, it is already lateral closing wedge.
Okay, sir. Thank you.
Thank you, Sumanyu, sir, for your talk. Now I'd like to request Dr. Bishnu, sir, our HOD sir to kindly present his talk.